Hi friends, today I welcome you all for the ultrasound diagnosis of TAPVC, total anomalous pulmonary venous connection. Quite a rare anomaly, but if you do a careful examination and systematic examination, it's quite easy to diagnose. And out of the different types, today I'm going to discuss in detail about supracardiac type. Now, normally we know that there are four pulmonary veins that carry oxygenated blood from lungs into the left atrium. In the case of TAPVC, all pulmonary veins drain either directly or indirectly into the right atrium. And based on the site of drainage of the venous confluence, it can be divided into different types. Of this, the supracardiac type is the most common type of TAPVC. Second one is cardiac, third one is infracardiac, and the fourth one can be the mixture of the above three. And obstruction of the pulmonary venous return is quite common in TAPVCs. This is the diagrammatic representation of various types of TAPVC. This is the normal drainage of the pulmonary veins into the left atrium. We know this. Now this is the supracardiac type. The dotted lines indicates that the venous confluence is behind the atrium. You can see it is directed towards the it ascends upwards. The anomalous venous confluence is ascending upwards, and it joins the innominate vein and then drains into the SVC. So what will happen? This will also be dilated, and even the SVC also will be dilated. So brachiocephalic vein or innominate vein will also be dilated in addition to the superior vena cava. Another important point to notice here is that direction of flow. This is away from heart, whereas this is towards the heart. Note this. This carries some clinical significance. We will say that later. Now this is the cardiac type. In cardiac type, it drains into the coronary sinus. And then what drains? The venous confluence drains into the coronary sinus, and then which drains into the right atrium. The third one is infradiaphragmatic, where it forms, the venous confluence form a vertical vein, and then it descends down along with the esophagus. It will be quite thin, and the direction will be from the cranial to the caudal, and then it will drain into the portal venous system, and then drains finally into IVC. Now let's see a case of supracardiac type of TAPVC and some of the important features that will help us in diagnosis of this. So when you do a sequential segmental analysis of fetal heart, you will land up in four-chamber view. When you start seeing it, the four-chamber view, what are all the things you see? First, you look for site. This left side, this right side, this the spine, aorta. Yes, the heart is in the left side. Site is normal. Size 1/3, 1/3, 1/3. So yes, size appears to be normal. Shape. Size of the heart as whole. Shape. Now you can compare it with the normal 4-chamber view. So now what is obvious is the right atrium is prominent over here, whereas here it's almost of same size. Here left atrium appears smaller, right atrium appears prominent. There are quite a number of differential diagnoses for enlarged or prominent right atrium, and TAPVC is one among that. Now look carefully into the 4-chamber view and in particularly into the atrium. Now what about the contour of this left atrium? It is smooth. This is the normal left atrium. It should not be smooth. It should be interrupted by something, which is the pulmonary veins. So when you see a smooth contour, suspect TAPVC. Now look at this both. When you compare this both, you can see the distance between the left atrium and the aorta is smaller. When compared to that, this appears more, right? So this is also one of the parameter which can be used indirectly to suspect the TAPVC. This is that one is called post left atrial space index. Now you can see the pulmonary vein clearly joins into the left atrium, whereas what you see here does not join the left atrium. It's clearly cut off. So this is the venous confluence which is seen behind the left atrium. This is the venous confluence seen behind the left atrium and seen between the left atrium and the aorta. Its shape can be of different shapes. Now let's come to the 3-vessel trachea view in supracardiac type. We have already discussed about the flow. We know that the flow between the SVC and the anomalous venous confluence is of opposite direction, and then we know that the brachiocephalic vein can be dilated. We know that SVC can be dilated. So that's it. So direction of flow opposite, increase size of brachiocephalic vein and increase size of SVC. Okay, all these 3 points we know already. When we see 3-vessel trachea view, instead of seeing 3 vessels, generally in supracardiac type, we will see 4 vessels like this one. Okay, this is pulmonary artery, aorta and SVC. This is nothing but left SVC. But exactly in the same position, you may also see the abnormal venous drainage of supracardiac type. So how to differentiate between two? Between left SVC and TAPVC supracardiac type with 4 vessels in 3-vessel trachea view. So how to differentiate between both? Here comes the direction of flow. The direction of flow will be in same direction in the case of left SVC and right SVC, because both are draining towards the heart, whereas here the direction will be opposite. So this will be red color because it goes towards the, this is SVC, and this will be in the direction opposite. Okay, so this is one of the important feature differentiating between the two. Which one? Left SVC and TAPVC supracardiac based on trapezial tracheal view. Also, you can see the brachiocephalic vein or the innominate vein is significantly dilated in TAPVC. This one, significantly dilated. Whereas, this is commonly absent or small in the case of left SVC. We saw this already, dilated SVC. Now I think all of us are familiar with the diagnosis of supracardiac type of TAPVC. Now when you take the pulse wave Doppler of this abnormally connected veins, we can see that it is not a usual pattern of the pulmonary vein. This is because of the reason that it is not connected to the, this pattern is not there, right? That M pattern of the vein is not there because it will not reflect the left atrium. The waveforms are created due to the pressure changes in the left atrium. But this anomalous vein is not connected to the left atrium. Hence, they do not represent the typical waveform. And they may also be affected by the resistance of flow within these abnormal veins. And we saw that it's quite common in the case of TAPVC. Coming to the other types, when you see enlarged coronary sinus, what is the first thing that will come to our mind is left SVC. Quite common, right? Common things are common. So, when you see enlarged left coronary sinus, you will first think of left SVC. When it is not there, think of cardiac type of TAPVC. It could be a reason. Okay. Next, coming to the infradiaphragmatic type of TAPVC, we saw that the structure crosses from thorax inferiorly through diaphragm. It can enter IVC, portal veins, DV, or hepatic veins. Now, let us see what all we have seen. We can just have a look of overall view of what we have seen so far. So first step is look for at least two pulmonary veins, two normal pulmonary veins connected to the left atrium. If yes, you are ruling out TAPVC, that is TAPVC. Okay, at least two. If you don't see this, if you find right and left a discrepancy, then look for the other features. What did we see next? Smooth contour of left atrium, absence of pulmonary veins draining into left atrium, then increased retroatrial space, and look for the presence of venous confluence. That's the fourth point. In supracardiac type, enlarged SVC and 4 vessels in the axial abdomen. We can see an abnormal descending vessel in the case of infradiaphragmatic type. When you put the pulse wave Doppler, you can see abnormal venous flow. There is no pattern, no M pattern of vein is seen in the pulmonary veins, and this will help you in the confirming the diagnosis. And this is what we have summarized in this slide. I hope I have taken you through the case of supracardiac type of TAPVC.